Good afternoon, everybody, and welcome to QPS TalkTime. Today's session is Quality Improvement in Practice with the Lead NCHD programme, and we have some really wonderful guests. I'm joined by Dr. John Fitzsimons, co-host. So today you can follow us on Twitter via at QPS TalkTime or at National QPS, and you'll also be able to watch back this session along with all of the previous sessions on our YouTube channel. And just to say, there's a huge amount of resources there, everything from psychological safety to quality learning systems to improvement in practice. There's a huge range of resources there. And you can also follow us on LinkedIn. We're using LinkedIn a lot at the moment, so you'll find some of our resources on LinkedIn and also keeping up to date on different things that are happening. And you can also join our mailing list. So we have a mailing list that will share any of the up to date, and a lot of you will be on it, but we often get a few people that join us and that haven't been on this before. So feel free to join our mailing list as well. And you'll find that on our website. Okay, so in terms of today's session, you'll see there's an overview of the Lead NCHD programme, and we'll be going over to Sean in a moment on that and why it matters to frontline healthcare professionals, insights from the current National Lead NCHD Fellows, and an overview of current Lead NCHD QI projects. And in particular, we have two guests, Orla and Catherine, who are going to share some of their own work with us today. So you can see some of the names popping up there. Thanks very much. And just to say, Dr. Sean Casey and Dr. Daniel Cregan are both of the National Lead NCHD Fellows for 2023-2024. And Sean is joining us today. Daniel, unfortunately, has another engagement, but we'll hear from Sean to speak for both of them. And we also have Dr. Orla Kemple and Dr. Catherine Allen. And Orla is the Lead NCHD in Tala University Hospital, and Catherine is the lead in the Midlands Regional Hospital in Tullamore. So without further ado, we'll take down these slides and we'll go over to Sean, and we just have a few questions for you, Sean, as we get started, just to give us a sense of the actual program. So we might start off with you might tell us a little bit about yourself and how you came into this role of the National Lead NCHD Fellow.
Yeah, hi Juanita, hi everyone. It's a great honor to be here. I was surprised we've been following the QPS TalkTime piece for a while now. It's a huge honor to finally be here and talk on this platform. So thanks for having us here today. In terms of my background, so I'm a pediatrician. I completed my pediatric HSC in July last year. I've done all my training to date in Ireland, and I'm very proud of the training quality here in this country. I'm a pediatrician. My special interest is pediatric emergency medicine. So I'm currently dialing in some prominent emergency departments from the front lines. And I also have an interest in, initially it was physician well-being actually that got me into it. So I was chair of the RCPI Health and Wellbeing Committee for probably too long, I suppose, to the detriment to my own well-being, probably at one stage, but for about 6 or 7 years I chaired that, which was a lot of high quality outputs targeting kind of the well-being of trainees within RCPI. And then eventually I realized that there's only so much I could achieve within that pool. So we set up a National Health and Wellbeing Committee, gathering the heads of all the training bodies to kind of promote wellbeing initiatives. That was kind of my introduction to kind of the quality improvement and management space as a clinician. And then moving forward through my training, I got more involved in, say, frontline quality improvement projects like Learning from Excellence, which Catherine, I believe, is going to talk about later on. And that was a really exciting project that John Fitzsimons and I was conducted in Temple Street a while ago, and a few other projects like rolling out wellbeing initiatives and strategies for NCHDs. And I became more and more involved in kind of management and kind of representing NCHDs and being the NCHD voice. That led me to take on a fellowship in healthcare consulting with PwC last year, which is run through our CPI. And that gave me a lot of exposure to kind of healthcare management at a macro level, external to the HSE. And then eventually I said, well, this year, why don't I follow on that thread and do a fellowship within the HSE in management? And ultimately that led me to take on this role as National Lead NCHD along with Daniel, who's otherwise engaged today. So yeah, it's been a really exciting opportunity, and the journey so far has been really interesting.
Okay, thanks very much for that. It's quite a broad range of experience, I suppose. And just to check with you, would you tell us a little bit about the Lead NCHD program, just for people that may not have heard of it before?
For sure. The Lead NCHD program is a really exciting opportunity for NCHDs. It started about 10 years ago. I suppose the HSE recognized that there was a need for, well, two things really. The HSE wanted to learn from NCHDs, and also wanted to give NCHDs an opportunity to learn from the organization and learn how you can improve your management skills. I think recognizing the fact that nowadays as consultants, in the medical sense of a consultant. It's more than just having the technical know-how or the hard skills. As well as the clinical acumen, you need to have organization, management experience, kind of to become a modern clinical leader in the environment that we work in. So it rolled out the NCHD or the Lead NCHD program about 10 years ago, and it's really ballooned in size now, which just is a testament to how successful it's been. So a Lead NCHD is the local representative for their NCHDs within the organization. It's not a union role, it's like within the HSE. So there are about 9,000 NCHDs in the system. They're all represented at local level by about 100 Lead NCHDs, and those are based in the acute hospitals, the CHOs, the community health organizations, and public health GP. We've got 100 leads in the system now. And then those 100 leads feed into my office, which is myself and Daniel, the National Lead NCHD Fellows. And then we, as an entity, exist within NDTP, which is National Doctors Training and Planning, the branch of the HSC that looks after the training, planning, and education of doctors. So it's a really good opportunity for NCHDs to get bi-directional learning. We get to represent our fellows and our colleagues within the HSE, within the organization, to promote change. And we also get to learn from the organization, from the executive, local level executives, in terms of how to actually run a healthcare organization. As part of their tenure, the Lead NCHDs, typically they're elected for a year. They engage in quality improvement projects. So we'll be hearing from Orla and Catherine representing our cohort in that sense. And they also attend like workshops and things that we run where we get to teach them about management and things like that.
Okay, that's really helpful. Thank you for that. And I know that we're going to talk a little bit more later on about the broader, I suppose, projects that are done, by staff in that role, and we'll get maybe a flavour of some of those later on. Just to check with you, do you think this work is important within the system? Do you think this is stuff that people will be doing anyway?
I think it's hugely important because part of the challenge, I think, in NCHD experience is we don't feel very often like we belong to the organization. So the common tagline is NCHDs are long-term employees of the system, of the HSE, but they're nomads within the system. So we're the longest standing nomadic population within the organization. And that can lead to a lot of disengagement, a sense of lack of representation, a sense that we don't belong to the HSE. The HSE is talked about as external to NCHDs. But we are the HSE, like there's 9,000 of us. Very often most patients, most of their kind of, certainly at clinician level, their engagements are with NCHDs. So we very much are the front line, the front of the front line. And I think it's important that we are represented in that space. I suppose if you can't see the representation you want, you to represent yourselves. And I really do believe that it's important as well for NCHDs to know how this system works, because as well as the organization learning from us, we have to learn how the organization works to achieve change. Often when you speak to NCHDs, they know the solutions, they just don't know how to go about achieving them. And this is the space they need to be in to learn that. How can you meet the movers and shakers when you have the right problem, right solution, how you can actually get it realized. So I think it's hugely important, and it's a testament to the fact that I think initially when it was piloted almost 10 years ago, there were a handful of NCHD leads across the country, and now there's over 100 of them, and it's continuing to grow. There's more and more demand. So I think absolutely it's a vital part of what we're doing. And I'm really proud of the program. It's modeled, I suppose, the American model is they've got a similar one in terms of kind of chief resident. But I think what we've done here in Ireland is really bespoke, really niche, and adds a lot of value to the organization.
Yeah, no, that I think that, thank you very much for that. It definitely sort of captures something within the system that's emerging, and I think that the knock-on effect of that will be seen as time goes on, as well as more people take up that role. John, I might bring you in there if you don't mind. You've obviously, you're consultant pediatrician, in that space. This is a relatively new program, but you've been involved in it over the last few years. Would you start to see the impact, within the organizations that you're working in?
Yeah, well, thanks to Sean there for a nice introduction to the program, and I've been involved over the years, and other colleagues of mine. I think most recently, Rob Cunny, my colleague from Temple Street, we've been asked in by Sean to help provide some coaching to the program, and and it's great. I mean, there is a great enthusiasm. I think there's been a great openness to, I think, bringing QI into maybe what was maybe kind of complementing more traditionally kind of skills like audit. I think there's been a great interest in QI, and I think, like Sean said, that the NCHGs are the nomads within the system, but they're also that gives them this great insight into things. You know, they've come from places where they've seen problems been addressed or solved, and they can often you know, bring those solutions around the place. So they're like vectors of good change kind of throughout the whole system. And so I think it's really valuable, I think, you know, both you know, with that group within the system, but also I think in your training as a doctor, I think it's really important to have good basic QI skills to understand kind of, you know, what it is, you know, to complement, you know, other skills that you have, your clinical skills, your research skills, and what you'll, you know, do an audit. And so I think the program has been great at trying to give people access, a little bit of time, some exposure to this, and in one sense, it's just permission to do stuff, you know, and to try things out, to try and make things better. And I think, you know, as you'll see today, many of the projects are succeeding in that sense.
Yeah, no, thanks for that, John, and thanks for sharing your insight, because I think when you're watching it from a different perspective, you have another lens on it as well. So it's nice to hear both Sean's perspective and yours. What we might do is we might go over to Orla, and Orla, you have a short presentation for us on a piece of work that you're doing at the moment. So if you'd like to introduce yourself, and we'll pop up the slides.
Perfect. Thanks so much, Juanita. And I suppose as Sean had said, thanks to QPS TalkTime. So really, we're looking at interdisciplinary teaching as an issue that has arose amongst the NCHD cohort in Tala University Hospital, which is a really large group of 300 NCHDs. Really, the mode which we've seen this become a problem throughout the year was poor NCHD attendance at grand rounds. For those of you who work clinically, grand rounds is a weekly educational opportunity, and the only one that exists in most hospitals that's interdisciplinary, and that encourages all members of staff to attend. It's mandatory in training programs. So for those of us who are registered as trainees, we should be attending these sessions every week. And in addition, it's really the only kind of interdisciplinary session where other disciplines come together, from surgical, medical, anesthesia, etc., and kind of teach across principles. And it's a really, really good learning opportunity, and one that I've actually not been able to attend myself for reasons which we might talk about later in the presentation. So this is kind of the problem that we wanted to address in terms of the QI project. So moving along then to our survey, this just outlines some of the data. Now, hopefully you can see some of that data there, but I can kind of highlight some of the main points to you. In the top left corner there, people felt that, yes, there was some teaching in their department, maybe up to 54% thinking that was sufficient. Unfortunately, up on the high 50% of NCHDs never attending grand rounds, and that's all year, and the other majority sitting in less than once a month or once or twice a month. Other doctors below getting the opportunity to attend intern and SHO teaching, but also struggling to attend these sessions. And then just commenting on the training schemes. So up to 52% of the respondents to this survey is on a training scheme, as I mentioned, with grand rounds is actually mandatory to attend. So then looking at some of the barriers then, so we examined the barriers in this survey, and I suppose I've highlighted the four main barriers that came up to accessing teaching. The grand round session is at 12 o'clock on a Thursday. Again, those of you who work clinically will know that that's not an ideal time for many, clashing with clinics, clashing with scopes, and really just not being friendly. NCHDs commented on poor advertising, and I think communication as a central challenge to this is something we might talk about later. In how we communicate appropriately to staff members, and equally, I think, across mediums to those who maybe don't check their emails or have access to email like NCHDs. I think there's a poor hospital culture around grand rounds, and I'd be interested to hear if this is echoed in other hospitals around the country. I think COVID-19 had a huge impact on this, and I think that that culture around attendance has changed. And then unfortunately workload just being too high, which is a difficult barrier to address. So then lastly, our action plan, or in terms of what we want to do with this QI and what we've started to do. So we've escalated this, and I think this is the first prong of of the project is escalating this to senior management. We've started a working group along with our learning and development team in Tala. So we're going to sit down and discuss this. And I suppose this is more of a slow burn in terms of the QI side, in terms of how we address these barriers and maybe continue this on next year. And then something I felt we could do as a group was, and start straight away, is a monthly NCHD-led teaching session. So we're starting our first session in April. It's going to be interdisciplinary, focusing on topics and discussions that will be of interest to all NCHDs, not just a specific area. And as you can see in the survey, up to 84% of the NCHDs who responded to the survey were interested in this session. We want to have it sponsored by coffee and have it as an opportunity in the morning time before starting work, that you get your day started by talking to other colleagues, and also uninterrupted by your working day as well. So that's, I suppose, a nice summary of what we're doing. I'm hoping to hear from some of you later on, and also to learn as well from what they're doing in Tullamore.
Brilliant. Thanks very much, Orla. And you know, it's quite interesting in terms of the challenges that people are experiencing in attending, and they might have desire to attend, but it's not working from a timing perspective, or it's not working from a, you know, as you said, a workload perspective. One of the things that had come up in our conversations was around the communication elements of it. We had a conversation, you know, in our prep about culture, you know, within a system, and how education can be part of the culture, and the focus on education can be part of the culture. So again, for anybody that's in that space, or if you come across it from a previous role that you might have been in, how do you prioritize education as part of the culture of an organization? John, I might bring you in there just from your perspective, and you've obviously worked on a lot of QI projects in your experience, you know, over the years, and in particular with your work with the diploma. Is this something that you've seen before? And would you like to tell us a little bit about what might have worked in areas that you've seen?
Yeah, look, I think the issue that Orla's talking about there, I think, is probably widely experienced. I think, and I think after COVID as well, I think things have been more challenging. In one sense, the tools that maybe make it easier, such as doing some of these things online, you know, also have a kind of a double edge to them, in that maybe people are less inclined to attend in person. And I think in a lot of places now, there's been a real move to try and get people back in person, because you know, we got to get that balance right, I think, between facilitating, you know, people to go to things when they just can't, and being there, because so much I think happens alongside the being in person. I think you know, and part of this is about relationships, and getting to know people, and even just, you know, the chatter or the conversations on the way in and out of the room, I think are so important. You know, I think there's probably not a one size fits all, and I think, again, that's maybe where, you know, some of the opportunities for QI, for NCHDs, and for any of us, are how do we improve, you know, how do we use QI to improve this problem, or to tackle it, you know. And I think, like all these things, I think getting a bit of data, trying to figure out, you know, are there particular groups or people or times kind of that aren't, you know, working, and then trying to come up with some ideas, you know, and like I said, every place is probably going to have a slightly different solution, I think, in order to try and meet that. And technology will be part of the solution here. I think it's not the enemy, but I think we also need to think about other solutions. I think, you know, consultants have a big role to play here as well. And I think, you know, even from our own experience here, we really do try to get as many consultants as we can along to teaching in person, you know, because I think that does help to drive the culture, like you said, of this is important, and this is something that we want people to come to.
Yeah, and it is fundamental to have that leadership and the visible sort of support, and seeing consultants attending it themselves. I think then there's more of a, you know, a sort of a feeling that it's okay to nearly attend, that it's, you know, it's actually, you can prioritize this, that this is part of the work, that it's not an added extra, that the learning is actually part and parcel of it. I just see Sinead Murphy's put into the chat there, and thanks Sinead for that you've started to use a hospital buddy to communicate grand rounds and record attendance at CHI, and that you provide lunch every week, and both are working quite well. So that's a really helpful suggestion. So thanks for sharing that. And at any stage, if people do have other things or things that you find useful, you can link in with us and we'll pass on the details on to Orla. But we will come back to it in a moment again. But thank you for that, Orla. We'll go on now and we might pass over to Catherine. So Catherine, if you'd like to introduce yourself and share your piece of work there in the Midland Regional Hospital in Tullamore, that would be wonderful. Thanks.
Thanks, Juanita. So my name is Catherine. I'm a gastroenterology SPR and I'm the current lead NCHD in Tullamore Hospital. So myself and my co-lead NCHD, Stuart, we are looking at bringing in a QI project called Learning Through Excellence. This project is still in its infancy, but I'm happy to talk to you today and get some feedback and maybe some ideas about what is going on in other institutions with regards similar projects. So within, the hospitals, I think we're all familiar with the concept of negative feedback, particularly as NCHD's training. And, there is the concept of incident reporting, which isn't meant to be viewed as something negative. It's meant to be a learning opportunity, but people are still cautious and a little bit wary when they hear that incident reports have been put in, especially if you're involved in them. And then on a more anecdotal level, we're all familiar with getting negative feedback, on the ward. For example, there may be a cross family member, people might have nail varnish on and they get their wrists wrapped for that. So we're all familiar with that. However, data has identified that there's a phenomenon of a second victim around adverse incident reporting in healthcare, whereby it can be quite unpleasant for the people that are involved in it, and it can foster feelings of self-doubt and anxiety. So the second victim is a common problem across healthcare organisations. Half of healthcare victim workers who have been surveyed report that they've been involved in an incident in which they feel that they were the second victim, and this affects their confidence in clinical management and affects their self-esteem. And signs and symptoms can be include grief, withdrawal, and anxiety. So in our institution, we put out a questionnaire to our NCHDs. 46% reported that they never have received any positive feedback. However, half of the NCHDs have received negative feedback. But 100% of them said they feel the positive feedback helps with learning and would foster a more pleasant working and training environment. And this is important, I suppose, because you want to create an institution that attracts NCHDs, that it's pleasant to work and that people learn from each other. So it's been identified in data that there may be a greater emphasis that's placed on examining failures rather than what goes right. And in the UK, it started in paediatrics in Birmingham, this Learning from Excellence program, whereby you don't just report what's negative and what's going wrong, but you also report what's going right, and areas whereby staff have performed very well. So the theory behind this is that it would enhance patient outcomes and positively impact resilience and culture in the workplace. And the data that came from this Learning from Excellence program was very good. People felt that staff morale was improved and the quality of patient care was improved as well. So in our institution, what we wanted to do was something similar. We wanted to provide a way that people could give positive feedback, whereby they see a colleague that does something well, a good interaction with a patient, a good interaction with a family, and they would have a way of feeding that back to the person in question. So we've been liaising with our management and our communications officer. In the UK, this was done virtually. However, we think the logistics of this will be quite difficult for the moment. What we're doing is a post box in the lobby with a feedback form, whereby you witness something that is positive, you can anonymously fill it out. At present, the NCHD committee is going to go through these, and we're going to liaise with our communications officers and get this feedback put into our monthly journal, so our monthly newsletter, and we let the people know individually that positive feedback has been made about them, and we're also going to promote this initiative to grand rounds. At the moment, we're not doing it for the public. We're just going to keep it within the hospital, but we're going to involve all disciplines across nursing staff, dietitians, radiographers, etc. It's not just for NCHDs. and how we're going to see has this worked and is this a positive thing. We're going to re-audit our NCHDs and we'll present the data then at our next Lead NCHD Day. Thank you very much. I'd be happy to take any questions.
That's brilliant. Thanks very much for that, Catherine. And I know obviously Sean and John, you've worked on this in Temple Street as well. I suppose one of the things that comes to my mind is, you talked about the other disciplines, Catherine. Is it challenging? From an NCHD perspective, obviously there's quite a quick turnaround in terms of people's rotation through services. Is it hard to make those connections to connect, to link in with people?
I think in a bigger hospital it would be, but Tullamore is quite a small hospital, so we're quite, you kind of would know a lot of the staff that you're working with. I definitely think in one of the bigger Dublin hospitals it would be trickier, but I think it'll be okay in Tullamore.
Perfect. And Sean and John, from your own perspective, I know, John, you've just shared some stuff there in the chat. From your perspective of implementing this in a different space, was there sort of key learning that you had from a QI perspective on this particular piece of work?
Yeah, Sean, you led out on that in Temple Street in ICU, didn't you?
Yeah, ICU and then in ED. And I have to say, as well as being a really important project, it was a really fun project to be involved in. John mentioned about audit, and I've done some clinical audits in the past, and they're really important for patient safety. But this was actually a project that you'd almost look forward to meeting up and planning on it, going through it. It really was a chance to engage our creative side. What I think worked really well for us in Temple Street ICU was we were very keen not to make it an NCHD project. As you mentioned, Juanita, how do you engage the other healthcare professionals? So from the outset, I was very keen that this would be owned by the whole department, not just say myself and John and the clinicians. So we got together a team of Learning from Excellence champions, and we had representatives from every branch of the department. So we had from NCHDs, myself, we had a medical consultant, we had a staff nurse, we had a CNM, a clinical nurse manager, we had administrative staff, we had all the different disciplines, a porter, we had physio to represent like the HSCP. So we made sure that everyone felt it wasn't just, oh, that's the NCHD project, it's, oh, that's the department's project. And then we tried to look at barriers, what would prevent people from submitting these. And so we came up with the QR code system. Catherine's got the hard copy forms. And I think really it's a testament to you roll it out in whatever way works for your organization. And that's quite important as well. That's something that Catherine's identified there is you find out, like, if there's a main entrance to the hospital and everyone's going past that and the box is there, that's beautiful merchandising and branding because it's very visible, For us, we felt that the QR codes were a bit more niche, but I think what works well is the Learning from Excellence movement in the UK have loads of resources, but that you adapt those to your organization. And that's why it's cool having all the representatives from our department. We got to problem solve around what do we think the barriers would be and how can we overcome them. Yeah, I don't know, John, if you had anything else to add.
Yeah, I've done a couple of these projects. The one you mentioned there, Sean, in Temple Street, we've done one in Drogheda before. And every time, I must say, they are incredibly positive, and Catherine's dated there again, 46% of people saying they've never, they can't recall ever been praised. That's such a terrible indictment. I think one of the easiest things we can do is thank each other every day, and acknowledge the work that people do. It's such a simple thing, but it is so important in everyday work. And I think, Sean made reference again, the Learning from Excellence, I think, project in the UK has become a movement, and I think it is something that people are taking up in different areas. And like Sean said as well, they're adapting it, to their needs. And they've added in a few other things. There's a concept called appreciative inquiry, which is a kind of technical approach, but at some level it is what it says on the tin as well. It's asking questions and appreciating, the good things that you find, and trying to kind of realize that we often have a lot of assets that we don't maybe acknowledge, and tapping into that. One of the things I put in the chat was a project that they did called Praise, which was about improving antibiotic prescribing in sepsis. And again, the way they approached that project was it could only happen through positive feedback. All of the changes happen through positive feedback, and they managed to make a significant change. So unfortunately, sometimes we're hardwired to think that we can only get better by being critical, but actually, being positive and being acknowledging all the excellence that happens is just as effective.
Yeah, and I think Catherine, you'd mentioned about publishing it, in the journal and the newsletter, and that's hugely important, because like that, the positive deviance, the examples of really good stuff, people can pick up on that, and that gets lost otherwise. It is funny. You touched on it there, John, about not recognizing sometimes the positive work that's happening. Years ago, we did a piece of work with the maternity services, and we couldn't understand. They'd lots of complaints, but they'd no compliments. And it turns out that they weren't actually capturing the compliments, because they said, sure, everybody's happy for the most part. When they come into the maternity service, they're delighted. They go home afterwards and everything is good for the most part. And the sense was that there was no point in capturing the compliments, because they didn't really think that they were anything different and unusual. And in actual fact, it was a huge thing to be able to acknowledge the good experiences that people had. Really, really important. One of the things that's coming in there, and just from Sheena Bulger, and thanks for that, Sheena, is that they're in the infancy of learning for excellence in the COOM, and they've developed an online form that feeds into an email address and Excel sheet to record the data. And similar to Sean, they used a QR code there for that. And it's funny, I wouldn't have been a fan of QR codes until quite recently, and now you sort of you use them so easily, and so I think once you get past it, but it's something that not everybody is maybe comfortable with at the start. So it's nice to know that you can have the box that you can drop stuff into as well, that if you don't want to do that's an option for you. I suppose with all of this sort of stuff, and there was just a question there that Catherine had, was they were wondering, is there merit? Do you think a prize or an incentive would support people to fill in something? If it's a positive feedback form, would it support people to fill it in, or do we just rely on the goodwill and the sense of achievement that comes from seeing the positive stuff coming through? So if you wanted to pop in a yes or a no into the box, and I see Sheena decided against the prizes, they don't want it to be an employee of the month type of an award. You get people filling in the forms themselves, maybe, I don't know, but highly unlikely that anyone would have the time. But yeah, there is something about that. But if people want to pop in a yes or no to that, do you think there should be a prize or an incentive to sort of encourage people and to engage people in that space? And if people have other questions, you can start to pop them into the chat box as well. There's one or two just coming through there on the messaging, and just we might just start off with yourself, Orla, if you don't mind. Just we talked about the rotation of NCHDs throughout the system. Is there something in terms of how we sustain the QI work of NCHDs, and how we can support sustaining the QI work of NCHDs, that you might like to share, or that you might have come across?
I think for me, it's something I've thought about a lot this year, because the reason I chose this year to be or to step up to lead NCHD in Tallaght is because I was continuing here. I've worked here now it's on my third year in the hospital, and I felt that I was most going to be influential with that experience. And I think it has a huge impact on your experience when you know where you are, the people that you're working with. So I think handover between lead NCHDs is something that is going to probably be something taken on personally, but is going to have a huge impact in that space. And then outside that, I think in the broader space of audit and quality improvement, you really just need leadership. And we have a lot of kind of subcommittee work going on in Tallaght that I find positive. I think this year we tried to kind of focus on NCHDs stepping up to lots of different roles across our NCHD committee, rather than focusing on the lead NCHDs spreading themselves too thin, and maybe kind of championing other roles as well. But I think there's a huge delay in time then come July, August, September, in being kind of these summer months of the year. People are settling in, and there's a lot of time lost before things get picked up again. So I'm not sure how to tackle that, but I think leadership in those areas is extremely important.
Yeah, I know I'd mentioned a colleague of ours, Ronan, had spoken, he works in clinical audit, and had spoken about you know, having an actual sort of a log of the different projects people had been involved in, whether it was clinical audit or an improvement piece of work, and the next person coming in could select from that list and then contact them. And then over a period of time, you might have 3 or 4 people working on the same project, and they came together and wrote a paper about it so they could then share the learning. But it allowed that continuity. And that's not always possible, but it definitely worked for them, and it was really, really helpful. Catherine, just, you know, if you have anything to add to that piece on sustaining, but equally, you know, you might have some thoughts on how can we support NCHDs in this work. You know, as you said, like Tullamore is good in that it's quite a small hospital, well, big small hospital, as they'd say. But you know, are there things that would support NCHDs as they're coming into getting to know people, getting to know colleagues in different areas?
Yeah, I think as Orla was saying, it's all about continuity, and the summer months are quite busy in hospitals with all the new starters. You know, it's not just regs, you have interns, you have SHOs, you have everyone starting afresh in July. I think, you know, this would be a huge thing, but if, you know, people kind of generally know from about March time which hospital they're going to be placed in July, I think an early expression of interest in who wants to be a lead NCHD might be beneficial, because then you could have someone appointed before they even come to the hospital, and then it would facilitate a handover from the current lead NCHDs to the new one if one's already appointed. Like for us in Tullamore, it wasn't until late August that we got appointed. So I think, you know, for someone coming in, it's much easier to get involved in a project that's already taken off rather than starting again from scratch. So I think that would be something that could be looked at potentially in the future. With regards to our specific project, keeping that going, I think that's the benefit of us involving everyone, including nurses and radiographers, and not just having it for NCHDs, that, you know, there'll be that buy-in from other healthcare staff, so it'll be more likely to be kept going than, say, a bunch of new doctors who have never heard of it before.
Yeah. Okay. Thank you for that. Yeah, and you're right. It is that sort of that having that sort of, you know, advanced planning, I think, is really important. And sometimes when we're in the middle of this stuff, it isn't always feasible or doesn't always work out. But knowing those things in advance would make a difference. And then the next challenge would be, if you did have that expression of interest early, would you have the time to be able to follow up? And then you'd have to make the time, which would be the next part. And just to say, there's sort of mixed feedback coming in on the prize. Some are saying yes, and some are saying no. Somebody said that Kathleen Murray had said there's nothing like an incentive. It'll make people aware of the importance of positive praise and how it makes us feel when we receive it. Everyone's excellent work deserves praise and to be recognised, and all the better if a prize is won while doing your best in your daily role. So you've something to think about there. No answers, but something to think about in terms of the mixed feedback. And Sean, I might just come back to you for a second, because you know, you've obviously got oversight of all of them, and I know there's a bit of competition between yourself and Dan in terms of, you know, the broad projects across the country. But, you know, are there other projects, you know, that you might like to touch on to give a sense or a sense of the type of work that NCHDs, lead NCHDs, are involved in?
Yeah, thanks, Monisha. It's hard to give it the attention it deserves. There's 100 lead NCHDs in the system, so I wouldn't want anyone to feel left out by me not mentioning the project. But I suppose in terms of growth, kind of headlines, there's some really exciting stuff. And what always interests me is how often the projects overlap. So one thing we did this year, Daniel and I, we were conscious that the 100 people, 100 leads in the system, all working on projects, and very often there's a lot of duplication in the system. You know, someone's working on learning from excellence in this site, someone else is working on it in a different site, and they're not talking to each other. Like you mentioned in the comments there, someone's running on learning from excellence in the Coombe, for example. We've run it across CHI, Catherine's running it in Tullamore. I'm sure, as you mentioned, the experience should be unique. It should be tailored to the site, but also a lot of the learning could be quite universal. Like, for example, if a site has run out of an incentivized or prize-driven initiative before, how do they find that? So you could, for example, set up a learning from excellence network in Ireland, and then everyone can share their learnings. That's one thing we try to do with the Lead NCHD program. At each of our workshops every quarter, we bring them all together and we get them to talk about their project. And you're surprised how often they're running the same project or similar type projects with slightly different threads. So we invite all the leads to kind of cross-pollinate their ideas and share their learning to reduce duplication, but also to ensure scalability. Like if you're running learning from excellence or you're running the Grand Rounds project in a site, we would hope that the learning can be shared across other sites and pollinated across whether it's your health region or your organization. And so that's one thing we're really keen on this year to promote, is just to make sure people are working hard, but also people working smart. A lot of the projects are themed around education and access to education for trainees. Some of the really interesting one involve particularly access to education opportunity for non-training scheme doctors, kind of a unique phenomenon in Ireland, where a lot of trainees have a lot of barriers to getting access to training and getting access to training programs. And so we have this phenomenon of training scheme NCHDs who are on a formal training pathway, and then non-training scheme NCHDs who aren't on a formal training pathway, and trying to overcome that gap and remove some of the barriers to education for the non-training scheme doctors, because they deliver just as much of the service as the training scheme doctors in most cases. So there's been a huge amount of interesting projects and a huge amount of diverse projects, but also a lot of overlapping themes. And one of the big challenges this year for myself and Daniel has been pooling them together into pockets where people can kind of share their project learnings across the organization. Because working in the well-being space, the physician well-being space, there's so much happening and people are doing so much good work, but often it's in silos. And I think building networks and building opportunities allow us to lean on each other and learn from each other in that sense. So yeah, absolutely. And specifically the learning from excellence piece, I mean, there's no reason that every site couldn't avail of that we couldn't have a learning from excellence network across the HSE for everyone to learn from each other.
Yeah, and it's worthwhile looking as well at the Q community. So I don't know if some people here, if you're a regular QPS talk timer, you'll be aware of the Q community. Some people aren't, but definitely there's an organisation called Q Community, and we have an option to join it for free in Ireland. And they have a community already around learning from excellence, and it's one that anybody can join. If you're a Q member, you can join it. So being able to tap into those networks where you have people doing this for a longer period of time as well, to save yourself the heartache of some of those lessons or early conversations is key, and potentially creating a subgroup then of people within the space here in Ireland would be hugely beneficial, because it means then that you have an existing platform or a network that you can tap into. You're not trying to do it on WhatsApp between calls. It's nice to be able to have somewhere where you can go and post your resources and that as well. And Eugenie has a comment here: is non-training scheme doctors are really the backbone of smaller hospitals and absolutely do not get any recognition. And that's a fair point, I think, and something that a lot of people would recognise as well. There's a few pieces here just in terms of some of the resources. We might just pop up the slides, but thanks very much to our panel so far, and I'll come back to you, John, maybe just for a word in a moment. But there's a lot of talk at the moment about how do we motivate people, how do we involve people in quality improvement work. And this is a really old clip, but it's a good one. And it talks about those intrinsic motivators, those things that really capture our motivation and why we actually do something. It's worth a watch if you haven't seen it before. And a lot of people will have seen this previously. But rather than focusing on what we're trying to do or how, it focuses on why people are doing something. So if you're trying to, focus on something like learning from excellence, instead of focusing on like that, here's the form that we fill in, and this is, what we're about doing, and this is, how we're going to do it, focusing on why we might do it, and that sort of that idea of being able to share with people, that heart of why we're actually doing it, that difference that somebody's making in your life is infinitely more motivating than the other side of it. And I know that, Catherine will have touched on some of that in her work locally anyway. So just that's a really good clip if people are interested in that. This is another really good resource for people that haven't seen it. It's the People's Needs Defining Change, and it's the Health Services Change Framework. There's a huge range of resources there if you're involved in quality improvement work that marry and complement the frameworks that we have within quality improvement. And there's a really good diagram there on what motivates people to change, and engagement and innovation is at the very top of that self-fulfillment piece. So it's worth a look at if you haven't seen it before. Okay. I think this is probably this is a really old slide that I have, but I wanted to put it in today. It's one we worked on a long time ago, a piece of work that we did with the Mercy, and there was a really interesting conversation at the time, and we did listening sessions with staff, but they said, we were going to focus on staff well-being. And interestingly, instead of things like yoga classes or maybe an extra day off in the week, which we thought people might really be interested in, the stuff that they wanted were the practical things. So the introduction of a handover or ward book, the review and improvement of the bleep policy, enhancing the on-call rota and distribution of work on nights and on weekend call, and then the introduction of additional computers to improve efficiency on the ward. So for anybody, if you're involved in quality improvement work, one of the biggest parts of it is actually identifying what the real problem is. And sometimes it's not the cause and effect that we might have automatically linked in our brains, that bias that's there in terms of thinking if we do A, this will be the direct impact of it. The type of challenges that were identified here were actual tangible issues that they had in the day-to-day work that they were doing. So being able to look beyond it and see, well, how can we actually focus on those things to make a difference with the broader well-being was really a key piece of that work when it was done. And you'll see that in any quality improvement piece of work that you're doing, that sometimes what we think is the problem isn't when we begin to start digging around. Communication was something else we touched on today, and there's a lot of resources there on the National Communications section of the website for the HSE in terms of communicating clearly guidelines and being able to tap into some of their social media policies and so on. But the biggest piece for us was using the metaphor, the analogy or examples, multiple forums, meetings, memos, newspapers, posters in places that people are going to be, like changing rooms or canteens, and then the repetition that you might need to share the message in multiple different ways, because sometimes there's not always a straightforward, if you put it up in one place, we don't always see it. You might need to use multiple different avenues. And then the leadership by example. So having, say, the consultants going to grand rounds, and then suddenly it becomes a priority for people. And it's a two-way piece, that if you're giving information, always have a way for people to come back and share information with you or share feedback. The biggest piece in all of this is sharing the story and saying thank you and celebrating the success, because very often with some of the quality improvement work, we just move on to the next project and we don't stop to acknowledge all of the work that's gone on, even getting it to this part, like Orla, the work that you've done to get the survey and to get the information. I'm sure you didn't have a cup of tea and a bun to celebrate even getting that much done. It was probably just on to the next thing. But sometimes when you're doing quality improvement work, you need to sustain it and pause along the way to take your time. These are some of the top tips that we've come across with some of this work. So the health sector principles of staff engagement and quality improvement are there on the bottom left-hand side of the slide, and they were developed by the Staff Engagement Forum. But these are other tips. So things like, when you're getting started, identifying the challenges together, that it's not just one person in a room coming up with the list, that there's more people involved, and explore, are we actually fixing the right problem? Being clear, what are we trying to achieve together? Identifying if there's power dynamics and the boundaries around my role. So do I have the authority? John, you touched on it earlier on, that it's giving people license to make a change. Sometimes it's giving permission, and sometimes we have perceptions about what do we have permission, what are we allowed to change and what are we not allowed to change. So thinking about that and thinking, is there a real barrier there, or is it just something that I have in my mind that says I can't do anything about that? Creating space for honest conversation and knowing that everybody's bringing something different to that conversation. Creating the networks and tapping into existing networks. Sometimes we don't need to create new networks, we just need to tap into existing networks. The diversity of ideas and involvement. So sustainable, powerful change comes sometimes from those diversity of ideas. And sometimes the person that you think is the devil's advocate can actually be the most powerful voice in the room, because they can ask you to think about things a little bit differently. Being aware of your own biases, their values, beliefs, and all of those link into insightful decision making. And then managing your desire to fix or control or move faster. Sometimes this work can take time, and when you're on a time frame or a deadline and you're trying to get something done, you just want to get something done. But actually, sometimes you need to slow down and let people catch up with a change or participate in it, so that you have a really meaningful engagement and outcome. Capitalizing on the social energy. So focusing on pride and the positive impact of work, focusing on the solution. So what can I actually control? They say 15% is what you can really control in any given situation or problem, and that others bring something else to it. Don't know where they come up with 15%, but it comes from some of our work on liberating structures. So don't ask me for the data, but they say about 15% is what we can control. And then acknowledging and celebrating the success. So and that includes a learning and a what, so what now, what did we do, so what are we going to do next, now what's next on the agenda. So there's some of the top tips. John, don't know, do you have anything to add to that from your own experience? Is there sort of a whistle stop in terms of some of the key learnings that we've had?
Yeah, they're all so important, and I think just listening to the session there, I think it's so important to acknowledge the work of the Lead NCHD program, and Sean and Daniel and Orla and Catherine here today, and all the Lead NCHDs. And I know people who are serving on this program are doing QI projects, and I think that has to be acknowledged and applauded. I think it's also important to say, that we need to be fair with the burden of improvement work here. The NCHD's primary role is to get training, and I'm delighted to see that QI training is going to be part of that, and it fits very well. But they also end up often being asked to to get involved in quality improvement work, because they're right at that patient interface where so much improvement needs to happen. But we need to make sure everybody else is doing their part as well. So I think it's important that everybody within the health service is learning about improvement and helping to make those efforts possible and to make them last. And I think some really important things there around handover, of from one group to the next. One of the things I'd like to see us do is maybe agree on some priorities, because I think so many of the projects every year are around things like communication, handover, that we should really be focusing on some of those big ticket items, and working with all our colleagues, nursing, HSCPs, and all the folks in management as well. That I think this is the best way to make these achievements and make it easy to do improvement work, so that it's effective and sustainable.
That's it. Thanks very much, Rajan. And I think that covers a multitude, and being able to pick out maybe those top priorities would maybe shape the conversation a little bit differently. You could have a National NCHD lead collaborative, maybe, I don't know. But thanks for that. Okay, so just in terms of resources to support you, the Q community is there. There's a lot of QPS tools and resources, and I'm going to mention two of them in particular in a moment. But there is the toolkit. There's also an improvement collaborative handbook, in particular from our colleagues in QPS Improvement. They do phenomenal work and really, really meaningful, I suppose, resources that have been tested throughout the system are available from the team. So have a look at the website to see some more of those. I'll talk about one or two of them in a moment. The QPS TalkTime, as I mentioned, they're all there in terms of the past catalogue of QPS talk times that people can tap into. There's also a prospectus of QPS education and learning. So no matter what stage you're at in terms of your QPS journey, there's something there for you on that. We also have our QPS Walk and Talk Improvement podcast series, and we're just finishing at the moment. Our last two podcasts are on sepsis, and we're hoping to release those in the coming days. And there's one for the public and one for staff. And we're working on a number of other podcasts at the moment. We've just recorded one on perfectionism in healthcare and how it can impact you and the team around you. So there'll be something interesting there coming out soon enough. And the last thing is just the website there. And there's a lot of resources there available on the website. So I mentioned our QPS improvement team, and two of our colleagues in particular, working with Marie Lorden Dunphy, Dervla and Roisin, have done work on this quality improvement toolkit. And I know, John, you would have been part of that at the start as well. And there's a whole load of resources there. So everything from doing your project and doing it on a page to stakeholder mapping, driver diagrams, project charters, and then some of the measurement stuff like a measurement plan or run charts or PDSA cycles. There's a whole host of templates there. And a lot of people don't know they're there and available to them, but they make your improvement work easier because it gives you sort of a series of resources that you can just tap in and out of if you're looking for it. And there's also information there on how to do an after action review. So say, for example, if you have a piece of work there that you love this piece of work, but you're moving on and you're rotating to a different service or you're changing roles, it can be helpful to do an after action review so you have a current status of where are we at. We've done this piece of work, this is where we're at the moment, if it's sort of finishing a stage of the project, and then you can pass it on to somebody else if they wanted to take it, because it's got a lot of key information in it then. And then you have a self-evaluation guide and a self-evaluation workbook. The other piece there is a lot of NCHDs and staff are involved in clinical audit, and our team, led by Magella Daly within the clinical audit team of NQPST, have an amazing suite of resources available now, and they have a lot of training available to people as well. So there's a practical guide for clinical audit. There's a lot of resources in that, but also I would say to you to keep an eye on the training that's available, because if you have to do clinical audit at any time, it's really worthwhile doing the training that's there, and you can follow them on Twitter at HSE NCCA. So there were some resources there. And finally, we'll just say that there's a short survey to fill in after today's session. Thank you so much for your time. We really appreciate you joining us, and we'll hopefully be able to post this soon enough up on our YouTube channel for anybody that couldn't participate today. But thanks for joining us. We'll talk to you soon.